So good afternoon, everyone. Once again, thankfully, this time it's connected. So vitreoretinal, I'm going to go very fast. So vitreoretinal surgery has evolved significantly, and Professor Natarajan and most retina surgeons probably know this. How the dangerous procedures that were being done earlier, unpredictable outcomes, very unsafe. Like you see over here, scalp punctures being made. This was in the pre-Gonin era, and post-Gonin era, there was a lot of understanding of retinal procedures that came into position, and then modern vitrectomy completely changed things for the future. Now, I'm going to stick to a few of the advancements in every slide. Ultrafine field imaging is something that is changing how we look at retinal vascular diseases, and it gives you a 200 degrees of picture of the retina. You have ultrawide field fluorescein angiography as well as ICG. Now, these are extremely good because you don't miss any peripheral vascularizations and any abnormalities in the periphery, as you can see in these pictures. Octa is, we are gaining more and more information about with Octa with each day. So essentially, it's a non-invasive procedure. There's no dye injection over here, and automatically segments and gives you information about different levels, whether it's a superficial capillary plexus or the intermediate or the deep layer. And now we have SS Octa, which also gives you a wider acquisition area of 12 by 12 millimeters as compared to the 6 by 6 that was there earlier. Now, one area that is advancing very rapidly is AI. Now, in ophthalmology itself, automated screening is essentially started with the retinal images, and it's been in use for a very long time. Now, it's CNN, these convoluted neural networks. They were trained to screen for diabetic retinopathy, and when compared to manual screeners with the ophthalmologists, they are quite comparable, with a very high sensitivity and sensitivity. So again, there's a lot of new information with artificial intelligence, machine learning, and deep learning. As you can see over here, now this picture essentially shows how AI works. In certain situations, it extracts imaging biomarkers, and this allows for prediction of visual outcomes. What you see in this image is a comparison between an automated segmentation done by AI and comparing that to different manual graders. And what it was seen was that there isn't any difference between the manual graders and the AI segmentation. This is extremely useful for picking up diabetic retinopathy, as Professor Nati has been doing for a long time now. Now, anti-VEGF injections, we know, is the mainstay of most of the retinal diseases that we have today. We have so many drugs, pralicizumab, faricimab, aflibercept, HD now. But what is also new is these port delivery systems that are making their way, which are going to last for a longer time. These new drugs called Cypor and Izervay, which have FDA approval for geographic atrophy. Obviously, they don't improve vision like anti-VEGFs, but they reduce the development of geographic atrophy or the progression. We have Zyper, which is a triamcinolone acetonide injection, which goes into the suprachoroidal space. With regards to surgical advancements, we also do a lot of scleral buckling with chandelier illumination. So essentially, this allows for better teaching and improved visualization of the retina while operating these retinal detachments. Posterior vitrectomy systems have evolved drastically in the last couple of decades, and we have Indian machines now which are almost as comparable to these multinational companies. We have very good platforms. Apart from this, we also had work going on with our own Professor Amar Agarwal, who was working on this hypersonic vitrector. Obviously, it wasn't commercialized, but which went up to cut rates of 1 million as compared to the 10,000 cut rates that we have in vitreoretina. The trocar system, the sclerotomy, that has undergone significant advancements, right from 20 gauge to 23 to 25, and now even 27 gauge, which are good. I mean, I remember you were one of the first people who started doing 27 gauge vitrectomy, but those cutters were very pliable. They were not very good. So, but the cutters that we have now, they're extremely good for even managing RDs with PVR. So these cutters have undergone significant amount of evolution as well. This is, for example, an Alcon cutter, no financial interest. So again, the cut rate is up to around 10,000 cuts per minute. They provide a bevel tip, so you can go much closer to the retina and operate. Chromovitrectomy, we've been using various dyes to enhance our visualization of the vitreous, but there are studies with regards to lutein and zeaxanthin crystals, which gives you a much better view as well as protecting the photoreceptors. Vitreous substitutes have undergone tremendous evolution, and there are new biocompatible materials that are also being researched. Intraoperative visualized systems, right from contact lenses to non-contact lenses to now some of us who are operating on heads-up surgery. So essentially, it's a three-dimensional surgery which you're looking at the screen and operating, as you can see over here. So essentially, it's you don't need a binocular eyepiece over here. You have your glasses, and you can. It can be not only very good for the surgeon's neck, but it's also a very good teaching tool. Intraoperative OCT helps significantly if you have it in your institute. Of course, you can, while operating itself, you can visualize the vitreoretina interface and make sure that your membranes have been peeled, there's no traction that's remaining. In cases of these, which Professor Muscati handles, so these cases, many a times you don't know whether to take them up for surgery or not. You see these bad corneas, bad visualizations. So again, a good way to check whether you should operate on these cases is by doing a diagnostic or a therapeutic endoscopic vitrectomy. As you can see over here, acknowledgement to Dr. Rajiv Reddy for this video. So again, if there is a good visual prognosis, then of course you can do a vitrectomy and then take these patients up for corneal transplants later. I'm almost done. I'll skip few with the video. So bionic eyes have been around for some time. Right, sir. Okay.
Timer is 6 minutes.
Okay, sir. Thank you. Let me take a break then. So bionic eyes have been around, but the most famous one out of them was marketed by Second Sight Medical Products. Our own Dr. Rajat Agarwal was the one who had made it commercial. The Argus 2 implant. So essentially, this is the only epithelial implant which was approved by the FDA. There were others, the Iris 2, the Alpha 2 AMS. However, they didn't see the light of the day in Europe. There is a teleoperated system that I was talking about earlier, which is called as Precise. Again, this was by Zeiss. This was the one that enabled surgeons. You can see the one on the bottom right over here. So this enabled one to peel membranes and do some basic procedures. So it's going to be a long way that any robot can replace any retina surgeon. Again, we do a lot of bimanual vitrectomy. Especially in patients with the tough membranes. So again, we have chandelier illumination, which essentially helps us to use both our hands. And as you can see over here, it makes cutting of the membranes very easy, and then move on to settling the retina. I'm going to skip some of these videos. So in summary, we have a lot of rapid advancements in VR surgery, which have led to enhanced safety, efficacy, and outcomes, good outcomes. So we need to have continued innovation and improvement, and a basic understanding of how we can improve things. Thank you very much. And with this, I would also like to invite everyone for MOSCON Goa. Most people are from Maharashtra, but whoever is not, we would love to have you at MOSCON Goa.